for Chair Foster.
All right, great. Thank you, Lindsay. So we're live. It's still February 6th afternoon, House Healthcare. And we did a really brief walkthrough with Legislative Council before lunch on H96. And we're going to start with Chair Foster and get his thoughts on this.
Thank you, Chair Black and the committee for having us in. I believe we're going to do two things today, which was one, discuss H96 briefly and give you the board's positions or my positions, depending on which specific provision we're looking at. And then second, we are going to finish the testimony of the Green Mountain Care Board overview. Is that still how you'd like to proceed? That
is absolutely. Thank you for reminding me that we're going to finish out because we had to truncate your testimony the other day.
Great. Okay. So I will go through our views on CON if that's what you'd like.
Yeah, great.
So the board does agree that the CON laws should be modified, and the rationale for that is we do want to open up our healthcare system to having additional low-cost providers enter the state. We think that would be beneficial to the healthcare system at large. We also think it can reduce some administrative costs, both for the care board to perform the work and for the entities submitting CON requests. So I've prepared to testify to specific provisions, and I'll do that. There are three CON bills, I think, currently in the State House. There's H96 in your committee, S10, and I believe it's S20, if my memory is correct. And there's some slight differences on some of the bill. So as to H96, H96 proposes increasing the capital costs, the construction costs, to $10 million for hospitals and non-hospitals. And that's a provision that I support. And I do want to make clear that I'm speaking as one board member. We generally do things by, three people have to support something. And we didn't have three people on one particular provision lined up, but there were more than three people that agreed with increasing the thresholds. But there was some different view as to should it be increased 3 times, which is what S10 does, or just straight to 10 million. And we had 2 people on each of those. But ultimately, we agree with increasing it, and I agree as the chair with increasing it to 10 million without a distinction between hospitals and non-hospitals.
When we did the walkthrough, Legislative Council explained to us that it's actually indexed and that it would be different now. Can you give us a rough idea about where it is right now? For the
Yes. I can. Currently is $3.7 million, $3.8 million for the construction.
Are the other thresholds increased as well?
Yes. So currently there's a distinction between hospitals and non-hospitals. So currently it's 1.9 million for non-hospitals and 3.8 million for hospitals. And S10 proposes going to 10 million for both of those, which I believe is a sound policy decision.
What about equipment costs?
Yes. So currently, equipment costs are $1.8 million for hospitals and 1.2 for non-hospitals. And we agreed with the S96 has a $10 million threshold. We believe a $5 million threshold would be more appropriate than all the way to 10 for equipment.
What is that? I think it's 2. It's 1, 2. Just for my knowledge, because I keep asking this question, it's kind of one of those things when you go to an auto mechanic and you have no idea how much something costs. What's the cost of a MRI machine cost or testing?
Yeah, so most of the ones that we've been historically reviewing for equipment cost would be exempted with the $5 million threshold. The vast majority of them. So I'll give you a sense. So the UVM Da Vinci robot purchase, which was in 2023, that was $2.5 million. So that would no longer be reviewed with a $5 million threshold or the $10 million threshold. The UVM MC CT scanner replacement, also in 2023, was $3.5 million. Would you ask for MRI? Rutland in 2022 did an MRI replacement that was 3.1 million.
Yeah, I don't have any idea how much these things cost. Thank you for that.
Yeah, most of the equipment would be exempted. So UVM did a purchase of 3T MRI and some construction. That was 4 million.
Okay. So you're recommending, or the board would like to see 5 million there rather than 10?
Correct. And it's a very expensive replacement, but most of what we see would be exempted anyway, even at 5.
Woody, did you have a question?
Well, could he give us an example of what would be over 5 million?
Did you hear that?
Yes, I can. So replacement equipment, let me think. So EMRs, the EMRs that we reviewed were over 5 and over $10 million. Those were, I think, 9 million for Mount Ascutney, and UVMs, I think the first one was 100 and something, 140 million-ish, something like that.
Okay, so electronic health records, medical records. And how about the operating costs? I think we raised that as well from 600 and something to 10 million?
500,000.
Oh, 500,000.
That's in 5, right? That's what you're talking about? A5,
So the
page 3 of 6, line 5.
Yeah, okay. So annual operating expenses, you're crossing out $500,000 in the bill, but I believe that it's currently $1.2 million for hospitals and $632,000 for non-hospitals. So I have a slightly different number from what it currently is to what's in this draft. And I don't know if I have a typo or if you do in the bill.
I think Jen explained that as because the Green Mountain Care Board has the authority to do indexing. What's in statute, in the original statute, won't line up with what current numbers are.
Yeah.
Can you explain what indexing is?
Yes. So simplify the process. We have authority to increase the thresholds by an inflationary factor. We have an inflationary factor that has increased each of the thresholds, and we've now automated that so that it automatically increases every year by an inflationary metric.
And you're okay with the 10 million?
We were lower on that. We believe that a $3 million threshold would be more appropriate.
Yeah, Leslie?
Yeah, can you explain to me what operating expense means in this case?
Sure. That's the cost of running whatever it is you build or add. So I'll give you an example. This is a made-up example. Let's say an outpatient surgery center wants to come in and their construction costs are $9 million. They would not hit the jurisdictional threshold of 10 million for a CON requirement. So they wouldn't need to submit one. And then another threshold you look at is the annual operating expenses. And if the cost to operate it is $5 million and the threshold's 3, and that includes like the people, the heat, like everything you're paying for your annual expenses to run the facility. If that's over 3 million, it would be reviewed.
Is that for 1 year or ongoing, or how does that work?
I don't have the statute right in front of me. I believe it is in either of the last 2 years.
If it's existed, then it wouldn't have any 2 year. That's why I'm confused.
Correct. If it's existing and you're expanding it, it does not get captured. If it's a new offering, it would be captured. So for example, we'll take the Green Mountain Surgery Center. If they're an existing facility and they want to add a new service, and that new service has an annual operating cost of $10 million, that would be reviewed.
Got it. Thank you.
All right. So 10 million construction, you support 5 million for equipment and 3 million for annual operating cost.
Correct. And I think those are right. This isn't like hard math here, really. Like you're not going to have a perfect answer, but having reviewed what we have performed CONs on, we think that those are the right thresholds. And then there's a couple other pieces. The conceptual CON piece, I think this bill moved it from 37 million to 50 million, which we also support.
That page, bottom of page 4, 5.
Yeah, 4 and 5.
So can you explain kind of briefly what that would be, what conceptual?
Yeah. So it's really, if you're planning a project and you think the project is going to be over $50 million, you need to get approval to do the work to go forward to evaluate it. Like, so if you do like the UVM outpatient surgery center, that was roughly $140 million or so, 135 or something like that. You would need to get a conceptual CON to do that, because it's very expensive just to plan and work and pay for all the expenses to get to do a CON for a project of that size.
Now, when someone applies for a CON, do they pay for that process to take place? Do they pay the board, the state, anyone to go through that process?
I have to get back to you on that. I mean, some of these things as the chair, our staff handle and lead a lot of that work. So I'd have to double check that. I think the answer is yes, but I don't have the detail in my head.
Woody?
Do they have to have the funding available before they even start this process? Or a portion of it?
I don't know the answer to that question either as to when they have to show the financing. They certainly have to by the time we actually review the CON. So as a board member, I don't make jurisdictional determinations, the staff does that. And then we deal with the actual request more closely. I don't know if they need to have the financing plan in place at the time of the conceptual CON, but we can get that information to you very quickly.
I think briefly we touched on when you were here last week, sort of, and I guess in my mind, the way I'm thinking about it is kind of a reverse CON, where if someone decides that they're going to close something or no longer offer something, that they would need approval, where currently there is no process in place, I believe, for that. Is that something you want to touch on, even though it's not in this bill?
That is correct. We do not review service line closures, only additions as per the statute. I think recent experience indicates that is something we should be talking about and considering as a state. And you could set up a process where you have a reverse CON to have board review and approve service line closures. That is something that if the state ends up going forward with the AHEAD model, that is part of the AHEAD model, is that that would be reviewed. So it would be consistent with that process. That would be, if we go forward, that would be there. There's some complexity to it in that you'd have to have another set of hearings and there'd be a timing issue of how long it takes to do that. But you'd have transparency into the decision making as to what services were reduced, and you'd have authority to look at, hey, can we prohibit this because there's other things you can and should be doing? Or that service is so important from our population health perspective or our state's plan that we can't authorize that. And I should add, other states do have this, do have a reverse CON.
Okay. Anything for Chair Foster on certificate of needs?
That last thing about the state.
Oh. Yeah, there were some questions this morning or early this afternoon around the very last exclusion that's been added. Construction, development, purchase, renovation of a healthcare facility that is a result of a contract awarded by the state of Vermont. First of all, could you maybe give us an example of something that currently the board would need to review or has happened in the recent past? And how you feel about this section?
I agree with the exclusion. If the state is awarding the contract and wants to go forward with it, we think that that's adequate diligence into the need and the appropriateness of the project. So we do support that exclusion. I don't think there have been very many of these where the state has chosen to go forward with a contract and then it became part of CON. We do have a current issue with SVMC and the mental health facility there. I don't want to comment on that too much because it's currently being reviewed and we're in the middle of that process.
Okay.
Leslie, Chair. Oh, sorry.
No, you can go ahead and then I think Leslie had maybe a follow-up.
I'll wait until the questions are done. There's two other things in S10 I wanted to flag and discuss briefly.
Okay. Leslie?
So I'm just curious about that. And I hear that, that you agree with the state exclusion. Can you imagine a downside to that?
I mean, if the state, well, yes, I think I can. If the state didn't look at it from the same perspective of need or resource allocation across the state, and then allocated the money and awarded the contract, that could be a net negative. I mean, we have a process where we review need very, very closely, and we have interested parties who give us information as to how it might impact them. And so, for example, just the SVMC one, there is an interested party who is taking a position that might be inconsistent with the state's position in awarding the contract. So the state awards might not have the same process of review.
Is that, but you're supporting it in spite of that?
I am.
Thanks.
Mari?
I have a question that was brought to me, and I hesitate to ask it without Jen in the room too, but I can also ask her separately. On page 2, line 2, refers to a new healthcare project, and then it includes the following 6 monetary thresholds. And the question was that the word includes was interpreted as meaning that those 6 items are not exhaustive. Another way of saying that is that not exhaustive, meaning that the Green Mountain Care Board can require a certificate of need for anything. So the suggestion was includes needs to be changed to means, a new healthcare facility means the following. Your thoughts on that?
I don't want to overstep, and your ledge counsel is phenomenal, as you all know. If you wanted, you could just strike the word includes so that it is the following, right? Or you could make it including but not limited to. So you could clarify that depending on which direction you want to go.
Okay,
Show them at line 21.
H2 line.
Lines 3 and 4.
Okay, thank you.
3, 4.
I have a question which is not in the bill, but is, you know, currently in statute. So I think when you sort of went over CON the other day, what things does the board take into an account when issuing a certificate of need? And do you feel as though that all those things are adequate? Should there be other things that the board should be considering? Are there things that the board shouldn't be considering?
Really good question. I think what we're reviewing and considering in this program are appropriate. And, you know, the feedback we've received from industry hasn't really suggested we're looking at the wrong things to my mind. I think the feedback from the industry is that it is expensive, it's time consuming, it takes too long, too much is reviewed. And I generally agree with those criticisms, and we have worked to improve those. And I think this bill takes us a lot further away from what I agree with are ways we can improve the program. In terms of what we review, we really review very closely the need. And the reason why is because if you build a facility and the need isn't there, it becomes a bit of a financial challenge to pay for it. So I'm going to give you an example. This is, again, a made-up example. But if UVM were to build an outpatient surgery center and spent $135 million on it, they no longer have $135 million to use for other capital projects. And if they're losing money because there isn't need, they will come and say that we need more rate because we're losing money on this service. So I think looking at the need is very, very critical. And in connection with that CON, we did find that there was need and we approved it. So we do look at that, but there's a lot more we look at. We look at the cost of the project. Should it cost $100 million or should it cost 75? We get a lot of architectural plans and estimates and experts who look at all these details to make sure we're not overly extravagant. We're paying for what we actually need to do the job. The other thing we look at more recently, more closely, is the price of the services that will be offered. So in connection with the UVM one, which was the most recent large one I dealt with, we reduced the price. The prices were going to be at a very high level for commercial payers. And we looked at the national average and said, you can charge a price that's consistent with national average. And so we said, we'll give it to you, but there's this condition that you have to have it at the national average for outpatient prices of outpatient surgery centers. And then with the Green Mountain Surgery Center, which I was not involved in, there was a condition that the services they offered had to be at the lowest commercial price of what any Vermont hospital charged, so that they couldn't charge more than that. So that helps consumers, and that's been a big success, I think, for the state. And the other condition we had on that one was that they had to take Medicaid patients. We required that they take, and they do take Medicaid patients. There's no cherry picking or cream skimming or anything like that. So those conditions, I think, are very helpful, and we look at those in the process.
Right. Did you want to tell us your concerns with, and you said S10?
Not concerns. I just wanted to flag there's a little bit of nuance between the two bills, and I figured I might as well take the chance to highlight those. So S10 has an exemption, an additional exemption for routine replacement of medical equipment that is fully depreciated, which we would support. And if it were in your bill, we would support that as well. So that's looking at, say an MRI that is fully depreciated and isn't used anymore and they need a replacement. We currently review those, and we think it would be acceptable to not review those.
Okay.
Having said that, the $5 million threshold or that we recommended would most likely not capture those anyway, but you could add that.
Okay.
That makes sense.
Yeah.
And then the other piece from S10 is they have another exemption that's not in your bill, which is emergency and non-emergency ground ambulance services, affiliated agencies, and equipment and supplies used by emergency medical personnel. We think that's also an appropriate exemption.
Can you give us an example of something like that?
Yeah, just EMTs, EMT truck, ambulance, those kinds of equipment.
Helicopter? Doctor?
Well, I think the exemption they have is emergency ground ambulance.
Oh, I thought you said ground and not ground, or I must have misunderstood.
Okay,
Thank you.
It says emergency and non-emergency ground.
Okay, got it. Thank you.
great. Thank you for that. So I'm looking at S10 right now and the numbers that you sort of provided us. And it seems as though H96 and S10, it's almost kind of meeting in the middle for the thresholds.
Correct. I think that S10 had different thresholds for hospitals and non-hospitals. That was one of the bigger distinctions. So S10 has it a $5 million threshold for non-hospitals and 10 for hospitals for the construction.
Okay.
Whereas your bill does not make that distinction.
Any other questions around certificate of need? All right, well, thank you. Thank you very much. And let's finish with the rest of our Green Mountain Care Board testimony. I'm assuming everyone's online? Because,
No.
oh, no.
Oh, Owen?
You want to come on up?
Oh, Lindsay will start.
Oh, Lindsay.
Hi, good afternoon.
Hi,
How's health?
Lindsay.
And thank you, Chair Black, for having us back to talk about our work. For the record, my name is Lindsay Kill, and I am the Deputy Director of Data and Analytics at the board. I'm going to start by going over at a high level what the data and analytics team and our other analysts at the board cover. You may hear me refer to our team as the A team, which is what we call ourselves. I also just want to flag that in the room with you all is Kate O'Neill, who was our director of data and analytics, and she's now the director of prescription drug pricing. We also have on the call our current director, Steve Andrews. So they will step in and help answer any questions that come up. So at a high level, the data and analytics team, or A team at the board, largely is responsible for stewarding the two statewide data assets, VCURES, the Vermont Healthcare Uniform Reporting and Evaluation System, and VUDS, the Vermont Uniform Hospital Discharge Data System. We steward that data through data governance, managing data release, data quality, and data management. We also are responsible for training and supporting users of the VCURES and VUDS data assets. So anytime someone gets access to those data sources, we help provide the expertise for their research. We are also responsible for in-house analytics and supporting contracted analytics that the board is responsible for. At a high level, most of that work falls into three buckets. That is membership enrollment reporting, so across payers and over time, looking at member enrollment expenditure reporting, and supplemental hospital reporting. And I say supplemental because we also have at the board, we have analysts serving the executive team, and we have analysts on the health systems finance team who have access to direct reports from hospitals through our hospital budget review process. And so what the A team offers is really supplemental information from the VCURES and VUDS databases. The A team also works on the certificate of need analytics support. So whenever there's a certificate of need application under review and consideration where there are data provided by the applicant that may need contextualization or additional research, the data team will step in there. New in 2025, is that we are taking on the annual hospital report, which is leveraging the VUDS database. And then all other legislative reporting as requested. Some examples of things that have been asked of the board, the A team and other analysts at the board are reference-based pricing, the Ambulatory Surgery Center annual report, and analytics supporting Act 167 community engagement reporting. So I'm going to pivot a little bit from talking about broadly what we do to diving into the VCURES and VUDS databases that we steward. So VCURES is our all payer claims database, which was established in 2009. Vermont was one of the first states to have an APCD. It's now in 25 states. Our APCD includes medical, pharmacy, and dental claims and eligibility for all of those types of claims. We have 100% of Medicare and Medicaid beneficiaries, and we have about 60% of commercially insured beneficiaries. The APCD is specifically a longitudinal database, meaning we can follow the same person with a master person index over time and across payer. To give you a sense of the size of the database, we have about 95 tables in VCURES, plus or minus reference tables. And one of our core tables that we often use is the medical table. And per year, the medical table has between 25 and 30 million rows of data. So it's huge. VCURES specifically includes information for beneficiaries in Vermont with Vermont insurance, meaning we receive claims and can see their utilization even out of state. Also important to note that the information that's in VCURES is only what's included to adjudicate a claim, meaning to pay or deny a claim. And more specifically, there's no clinical details from visits unless those clinical details get translated into variables such as procedure codes or diagnosis codes, things that would be used to adjudicate the claim. And we also wanted to call out that in VCURES, there's no patient identifiable data. And for certain types of procedures, we also have some provider data that are unavailable as well. So the way that we have the longitudinal data is through a de-identified master person index or master provider index. State entities and non-state entities both can apply to access VCURES either through a limited use data file or a public use file. These are two different ways of getting VCURES, and they each have their own process. The data in VCURES are collected quarterly and made available for analysis on that quarterly basis. The difference here is that CMS's Medicare data is on a slightly different schedule than other payers. And it's worth noting that the data from CMS right now are delayed more than 8 months. And so we are still waiting on the full 2023 calendar year with 6 months of run out and the preliminary 2024 claims. So at a high level, VCURES basics. Who's in the data set? 60% of commercial beneficiaries and 100% of Medicaid and Medicare beneficiaries. What's in VCURES? We have claims data from 2007, dates of service and forward. The people who are in VCURES are Vermont residents with Vermont insurance. We have, when do we receive this information? It's from insurers, third-party administrators, and pharmacy benefit managers. They register annually, and depending on the volume of beneficiaries they cover, they will report on a monthly, quarterly, or annual basis. but the files are coalesced and made available to us on a quarterly basis. How does this work get done? GMCB has a contract with our database vendor, OnPoint Health Data. They're responsible for collecting and curating the data from the submitters and making it available in a secure research environment for all users, including for the GMCB analysts. Shifting now to discuss VUDs. VUDs is.
Can I interrupt you really
Of course.
quickly? I think, did you have a question, Woody?
But I can wait after you, Chair.
No, you can go ahead.
Okay. I'm just curious with all this data on the claims data
Mhm.
and what is paid out, I suppose. Would this be used in our healthcare reforms with reference price basing?
I'm gonna ask Lindsay that question.
Was that
Your-
something you were gonna ask?
Your line of thinking is in line with what I was thinking with everything we heard yesterday about
Yeah.
reference-based pricing. So, you know, a claim's gonna have procedure code on it. It's gonna have, you know, facility or provider. It's gonna have the charge. It's gonna have how much was reimbursed, I'm assuming. Or the allowed amount from the insurer. So what do we do with all this data we're collecting? And are we curating the data to sort of get a better idea around prices, price variations, price comparisons between different payers, different facilities, different providers, different services? Are we using this data for anything?
So I'll address legislator. I'm sorry, I missed your name, sir. Woody.
Yes, you can call me Woody or you can call me Representative Page. That's fine.
Thank you. I missed your last name. That I was waiting for that. So to your question, the reference-based pricing study that was recently provided, that was using our all-payer claims database. Yes. The reason that we could use the all-payer claims database for that is because VHI for so the covered lives for whom that study was related to is the VHI and the VSEA, and those are groups of self-funded commercial self-funded plans which are compelled to submit to VCures. Not all commercial plans are, and so the APCD could be used in that case. To Chair Black's broader question, are there studies of, is there data available on reimbursement variation and price variation? Yes, they live on our website, with an important caveat that we're currently working on a new expanded report, a refreshed report that will look at all of that in more detail. So reimbursement variation that is currently on our website looks out of date because a different report is coming out, a price transparency study.
When is that due?
We're targeting June 2025.
Okay, great. Thank you.
Yeah, you're welcome. Any other questions about VCures or how those data are used?
I don't think so.
Okay. All right, so pivoting to VUDs, our hospital discharge data. These files are available annually and by type of bill. So there's inpatient, outpatient, and we have some supplemental revenue code files. There's around 2 million rows of data per reporting year, so a much smaller data resource. It includes all discharges from Vermont hospitals, even if the person is a non-Vermont resident and regardless of insurance coverage. The file does not contain any patient identifiable data or individual provider identifiable data, which is really important about the BUDS data. It is available only as a public use file and is shareable with state agencies, providers, payers, and researchers upon request. And I mentioned this earlier, but we are currently in the process of moving data management from where it currently sits at the Vermont Department of Health to our team at the GMCB. And so moving forward, we will be responsible for that annual hospital report. The data are collected monthly and quarterly for data quality checks, but is only available for analytics in an annual file format for research purposes. And I did just want to note here that the current data collection is over a year and a quarter behind due to hospital EMR transitions and the inclusion and expansion of the data structure to include CMS 1500 records. So again, at a high level, who is in BUDS? It's anyone discharged from a Vermont hospital, including people who did not use insurance for that visit, which is the self-pay. What is included? They are annual files of inpatient and outpatient discharges from all Vermont hospitals. For whom are these data? They are for Vermont hospitals, and it also includes the Green Mountain Surgery Center. When the data are collected monthly and quarterly for data quality purposes, but is made available for research on an annual basis. How do we do this work? We have an established contract with BOZ NSO to assist us with collecting the data from hospitals and preparing those data. And new this year, GMCB is taking on the data management role. At a high level, I just want to touch on a few pieces of analytic work coming out of the GMCB here shortly. We have our all-payer model analytics, which the A-team has supported since the all-payer model started. Those reports are updated annually, and currently we are awaiting the total cost of care 2023 and preliminary 2024 data for a report on total cost of care trends. We have the Health Resource Allocation Plan, which is the HRAP. That is really an umbrella report that covers lots of individual types of reports, such as reports on access and primary care. It encompasses the Act 167 data for the community engagement. Also, a recent report from last year was the Gender Affirming Care and Reproductive Services report. All of that is a part of HRAP. And we aim to update all of those individual reports under this HRAP umbrella so that the whole of HRAP is refreshed at least inside of every 4 years, which is what the statute requests.
I think Leslie has a question.
A question about HRAP, if I may. I just hit your link there, and I've been interested in HRAP. I'm seeing your last report was in 2020, and I'm wondering when you expect the next one.
So so there's individual pieces of HRAP that get updated on they get updated more frequently. So I'm not sure which piece of HRAP you're looking at, but I know, like, for example, last year we updated the hospital services inventory, and we updated, well, it was new last year under HRAP, but the Gender Affirming Care and Reproductive Services report and the Act 167 community engagement work came out last year, which is all part of HRAP. So
I'm looking at primary care.
okay, yeah. So the primary care report, that was if that's what it says the last time is 2020, then that would be correct.
Do you know when we could expect it or anything like that, or maybe not yet? I don't know. Just wondering.
Yeah, that's a good question. Right now we have some primary care reporting that we're developing as part of the AHEAD model if we move forward with AHEAD. But as far as that specific individual report, we don't have a timeline to update that. but I can certainly take that back to the team.
Yeah, I'd like to hear back. That would be great.
So are there any more questions about the first two reports I talked about?
I did have a question about the VUDs.
Mhm.
Really quick. So the information that you're pulling on hospital discharges, does that include diagnosis codes for inpatient admissions?
Yeah,
I'm just wondering, can we see trends of, certain admissions for various conditions?
yes, there are diagnosis code information on the VUDS data.
Okay, thank you.
Yep.
I think no other questions, so if you wanted to go on, be great.
So patient migration and patient origin, those are also updated annually. Our 2023 reports are estimated to be delivered in June 2025. The expenditure analysis also updated annually. We're a little behind on that report, but the 2021 and 2022 are estimated to come out here in a few weeks. And the 2023, which will get us up to date, we're estimating by December 2025. And then our annual statement supplemental reports, which is on our commercial insurance market trends, that's updated annually. The 2023 report is coming out estimated in April, and our 2024 data collection cycle has begun. So that's only a few of the reports that we do, but at a high level, kind of where we're at and what's coming. Any questions about those?
I think we're good.
Okay. I'm going to pivot a little bit to talk about the GMCB oversight of the Health Information Exchange. Right now, we are in statute, we review and approve the Health Information Exchange strategic plan, and those statutes are 18 VSA 9351A and 18 VSA 9375, the language here. And sorry, was there a question?
No.
Oh, okay. And we also have oversight of Vital the Vital to review and approve annually their budget. And that's from 18 VSA 9375 B2C. That language is there. And we just wanted to call out that we have some proposals for these two pieces of oversight. For Vital, we feel that they are no longer having trouble with their budget, and should the legislature concur, we'd like to be relieved of those oversight duties. And then for the VHI, we would like to have a more collaborative relationship with VHI, and reviewing their strategic plan rather than helping to create it puts us in more of an oversight and less collaborative position.
Leslie?
I'm just wondering if that means a statute change, like what has to happen to make that happen? Diane's nodding, so that's a good thing.
I think they're looking to us to possibly consider.
We're going to be looking at
Changing
from you.
And that concludes the slides from the data and analytics team. So I can hand it back to Chair Foster if there are no other questions.
I don't think any other questions. I think we're all set with that. I do want to apologize. I feel like sometimes I get distracted, and I want you to know the reason I'm distracted is because I think you put out the best reports, and I get sucked into looking at some of your reports. So thank you for them. We really do look at them, and they contain some really fantastic information.
Great, thank you.
And
Thank you. And thank you, Lindsay, for testifying. Lindsay is a real superstar data analyst for us. She led a lot of the work on the Oliver Wyman report, which had very, very complex data analysis, and Lindsay did an outstanding job. So our A team is really quite strong, and we're fortunate to have their work. I'll go through this really quickly, being mindful of time. ACO certification and budget review. We review ACOs differently depending on if they're Medicare only ACOs or if they are an all-payer ACO. So the all-payer one is only OneCare. We can go to the next slide. I've been thinking a lot about healthcare reform and how we've been doing it and is it working? And I think the jury's out on that with the all-payer model. We put out a report that was requested by the auditor of a return on investment analysis of the all-payer model. And the link is here, and this is sort of the summary of it. There's different ways to look at it, but and how. And in the all-payer model, what we saw is really, if there were, quote, savings, it was really accruing to the benefit of Medicare and not the commercial payers. And that wasn't what we were trying to achieve. So we have to really think about that as we go forward. And then just more broadly, listening to all the testimony the last couple of weeks in your committee, I don't think any reforms will work if there's not alignment at the ground level. And what I mean by that is the hospital board. Is the hospital board aligned to do what the state's goal is with the reform? And are the hospital leadership and executives being paid to accomplish that? So as a state, we've been trying to move healthcare out of hospitals, and we've honestly failed miserably. We have not been effective at doing that. And so we also want to control expenses. So if we're going to be achieving anything in our reforms, we have to make sure that the hospital boards and the executives are being rewarded and focused on what we're trying to achieve, which is expense control, lower commercial prices, better access, and moving care out of hospitals to more affordable places. And that is not always, that hasn't pulled through necessarily yet. I can do the next slide. A couple things we have done. So OneCare had generally around a $15 million budget over the years. And as we saw the results over the last few years, not really achieving what we had hoped for, we did reduce the expenses. Essentially what we did was we said, look, the administrative cost to run this healthcare reform at OneCare is too high. And we think those dollars should be better allocated towards healthcare, not healthcare bureaucracy. And so in 2024, we reduced the administrative cost by about $1 million, and we reallocated those funds to population health and primary care programs. We said you can spend $1 million less running this operation, and you need to spend $1 million more on actually delivering care. And then there was uncertainty as to whether or not the money going from OneCare to hospitals for primary care was actually being used for primary care. We couldn't get an answer to that, so we required it. And then in 2025, just recently, we did a similar thing. We said the budget is, again, too high for what we're getting. We're not getting the return on investment of this budget, and we reduced it by $1.5 million. And again, we reallocated that money to support all different types of care providers, including mental health and primary care. We want money in those places, not in administration. And so we took steps to do that. Go to the next slide. There was, we also had reduced some executive salaries in the OneCare context. They didn't make sense to us, and we didn't think they were appropriate. And so we subpoenaed information to get better transparency on it, understand why they're being paid. And we had to go to court because the subpoena was challenged by UVM, and UVM and OneCare. UVM owns OneCare, and the court agreed that we should have that transparency into why the salaries were being paid. And we did reduce the salaries or cap them at, I think it was national median, and required that money to be reinvested into healthcare. And that was also challenged. It went to the Vermont Supreme Court, and we believe correctly ruled that we did have such authority to cap executive salaries. So that was that. Next.
Oh, I
I
think
forgot this.
Woody has a question real quick.
The head model, who will own that? Is that going to be owned by UVM, or is that going to be?
Will own it?
Yeah.
Oh, that wouldn't have.
Oh, and can we
It
all,
wouldn't have.
Can we hold on one moment, Owen? I'm sorry.
I'm getting like a weird thing with the live stream now, so I'm just gonna stop it.
I think we're having problems with our live stream.